I'm really excited to introduce Michelle Henry, Clinical Dietitian at Children's Hospital, Colorado. Michelle is a registered dietitian with a master's degree in public health. She practices dietetics with an emphasis on pediatric allergy, gastrointestinal eosinophilic diseases, and behavioral counseling. Michelle, thank you so much for being here this afternoon. I'm going to turn it over to you and we will get started.
Welcome. Hi. I was asked to talk about the basics of nutrition that we deal with in eosinophilic esophagitis. And so I am going to go through basic nutrition needs for children. I'm going to outline the nutrition concerns specific to EOE and also talk about the ways that I try to help my patients and my families improve the nutrition intake in their kids with EOE. So first, to just review some nutrition needs, I've decided to start at the base of what it is that dietitians are actually looking for when evaluating a diet. And if this is too basic, of course, we have the questions to come up, as well as I've offered to give a follow-up to this if that's something that you all would like. So for this slide, I wanted to talk about overall nutrition for all ages. There are no magic foods that provide all the super nutrients needed. It's important to get a variety in the diet. In most cases, a variety is enough to cover the needs from vitamins and minerals. Where this gets a little bit more challenging with food allergies, and especially EOE, is when children cannot have a food or food group, or if they refuse an entire food group, for example. Perhaps they're refusing all meats or proteins, or in combination with maybe a vegetarian lifestyle that the family might have, also taking away some others that they can't have for EOE becomes a challenge. In addition, dairy can be a challenge as well. Obviously, that's the most common food allergy that we find related to EOE. And so that can be a challenge as well, just with the calcium and vitamin D. And then special attention must be paid to make sure that the child is actually taking specific nutrients from that food group, whether it's dairy or the protein group or so on, just to make sure that we're not needing supplementation, or if we do need supplementation, what that is. In my experience, though, I've seen many families for various GI diseases and food allergies that feel their child is not eating enough. And we find that the idea of enough, or what the appropriate serving sizes are for that child, is more than or what would be actually expected for age. And what I mean by that is the parents sometimes think that the kids really need to be eating more volume, more variety, so on and so forth, and really they a lot of times are doing okay. This is always a concern of the parents, and so my job for that actually is to help figure out, is this true? What does the actual portion size look like? And really look at their habits to make sure that their averages, their intake averages, are meeting their needs. So they're not going to eat the same things every day, or perhaps they are, but over time, weeks and days, they're actually meeting their needs. I feel like a lot of times in the beginning it helps to get a good idea of what's expected for age so that we don't get ourselves as parents frustrated and also not set the kids up for failure when we're serving them too much. So that's a long story for this tiny slide, but in general we're just looking for foods from all food groups or alternatives if we need to, such as dairy substitutes for dairy, that are fortified, as well as adequate fluids. That's a big one, good sources of fiber, and then supplements when we need to. So what does a balanced diet actually look like? It's all foods or food groups or substitutes as appropriate. And then adequate fluids. This is a common problem. I think I'm coming across it more and more these days than I did years ago. I've attached here a link that you can go to. It's actually a handout on fluid intake for age. And that'll kind of give you an idea of where you should be for your child. So with that said, though, there's a lot of times that, the recommendations are one thing and a child may take a little bit more, a little bit less, and still be hydrated. And so I want to keep that in the back of your minds when you're looking at different calculations for fluids or calories or so on and so forth. Every child is different, and so we can do our best to estimate, but the real picture is the child. And so if they are appearing hydrated and also medically presenting hydrated, then that's the true story. Lastly, on this page, I also have electrolytes, and this is becoming more and more important for those on formula-only diets. Reason being, there isn't as much electrolytes, sodium, potassium, things in them, as you might get in a full food and drink diet otherwise. And the only reason I'm bringing this up is I have had a few of my patients that actually have a hard time getting enough of these in, and they actually crave them. So I've had several complaints of patients who are craving salt and wanting to lick salt and so on. And once we dig in and figure out what it is that they're taking in, we find out that they're actually not getting enough of that. It's something, if you do come across the situation where your child is craving salt or other things, that you really should bring that up to your providers. I'm going to move forward. So calculating adequate protein and calories. As I mentioned, there is a big variance in terms of the amount of protein and calories each child definitely needs. There are obviously estimations, and at the bottom here I have the link to the USDA Food Pyramid Tracker. It will allow you to put in your child's height and weight and age, and it will give you an estimate of what they need for calories and proteins. Basically, you can go anywhere online or a book or any calculator. There's lots of apps these days. There are lots of books, online calculators, apps, so on, that you can use to calculate calories for your child as well as protein. And really, they don't substitute for a full evaluation. It really takes that full medical evaluation to really tell you exactly what it is they need. They may need more, they may need less. These estimations, and even from the government and the DRIs, are for healthy children when you use those calculations. And so that doesn't account for any medical issues that might be going on or their individuality. So they're meant for populations and estimations for that. But they are a baseline, so it's a good idea to start there. Going back up to the proteins, high-quality protein sources are something that we look for. You want to make sure that your child is getting complete proteins or complementary proteins, because there are times when those complete protein sources, the dairy, soy, and animal proteins, so the meats and eggs, things like that, are not able to be in the diet, or they can't eat them by virtue of chewing and swallowing and so on. So these are the two things when we're looking at protein that we are looking for. One question that might come up is whether or not the formulas are complete proteins, and they are. My next thing that I will go through is nutrition concerns specific to eosinophilic esophagitis. I bring this up just because these are treatments that are used with children with EOE, and these are nutrition risks. So systemic steroids are not indicated for long-term use, as we probably already heard from Dr. Furuta and Dr. Atkins. However, long-term use in other diseases has shown decreased bone mineral density, and that's with long-term use. Topical steroids, long-term use doesn't really have any identified risks yet. Short-term use, obviously, local fungal infections. With PPIs, there is a possible decreased iron absorption with that, and in addition, There are some studies in adults that show that you could have risk of osteoporosis and fractures. Again, those are adult studies only, but it's worth noting. That's why we are concerned about making sure that the diet has enough of the iron, calcium, and vitamin D in it. This slide, we're talking about classic clinical symptoms and nutrition risk. So here in this first table, you can see that the typical clinical presentation for each food group, starting with infants and toddlers, obviously feeding difficulties, which can lead to lots of things like poor weight gain, poor growth, and so on. So they can also experience delayed transition, so not able to take solid foods, purees, to soft solids, and so on. And then overall, because of all of these things, can then end up with less than adequate vitamin and mineral intake. The next group, obviously, our typical presentation is the vomiting and pain for school-age children, which can lead to just overall feeding refusal, which then would lead to poor growth and inadequate vitamin and mineral intake as well. These are just things that are risks. When we talk about a nutrition risk, it just means that when you have this disease and this is your presentation, these are the things that a dietitian or medical team would be looking at, whether or not the child is refusing to eat, if they have poor growth, and so on and so forth. For adolescents and adults, similar presentation types can also lead to inadequate vitamin and mineral intake because of food avoidance, and then also the possibility of poor weight for their height. Again, all possibilities, but that does not mean that every patient presents this way. This table is a table from a recent publication that I helped participate in, and it just kind of goes through all of the different nutrients that we really look at in eosinophilic esophagitis and food allergies in general. So it's a good resource if you're wondering, you know, my child cannot have, let's say, red meats, where else can they get their iron and zinc? And so that's a nice table for you. Of course, lots of information on the internet on the amounts of iron and zinc in different foods, as well as these other things. I would recommend making sure that if you are concerned about a certain area that you do ask your providers about that. Okay. For this section, I'm just going to talk about the ways that dietitians play a part in helping kids with EOE. And I'm going to start actually in the beginning. So at diagnosis, what I do, and I'm sure other dietitians do as well, is we actually look at the pre-diagnosis diet. So what is your child eating before they're diagnosed or before food allergies or additional food allergies are identified? What we look for is what they're able to take. What food groups do they take? Do they take from all food groups? And do they have a variety within each food group? And that's not just for colors of fruits and vegetables and things like that, but making sure that they have a variety of textures. And so if a dietitian is not working in conjunction with a feeding therapist, that's something that sometimes a dietitian does take on in terms of defining their abilities with the food groups. The other things we look at are overall calorie, protein, and micronutrient or vitamin and mineral intake. Sometimes we do that by 3-day diet records. Sometimes we do that by food frequency questionnaires. Sometimes just a 24-hour, what did your child eat yesterday or the day before? And a lot of times we start there and we can figure out what it is that might be of concern and then dig deeper if we need to. We also look at their weight gain and growth. Their prior growth history is also important. And then we do what's called in our world care coordination. So we work with the team members, we talk to the physicians, we talk to feeding therapists if they're available, we talk to all of the different team members in terms of our concerns so that we can all come up with a plan that works together. the next step, so after diagnosis, the next step where we have intervention is the treatment. And so I have been trying to be very conscious about giving every new patient or everybody who receives a new diet prescription education on their food eliminations. Even though I have lots and lots of families who are really amazing, and actually a lot of them are better cooks than I am, I try to make sure that everybody gets the same education from me in my clinic as possible. So when you get new food allergies or new things are identified, we're going to take new things out of the diet. I do the education on those. We also go over recommendations for substitutions, and the reason for that is to meet nutrition needs. There's lots of reasons to substitute foods for taste, for preference, for cooking quality, but our focus is to make sure that the child's still going to meet his or her nutrition needs. We also do some work with adjusting cooking methods when texture is a challenge. So if a child has a really hard time chewing things like steak or grilled chicken, things like that, we talk about how to better cook those, as well as other foods, and especially identifying foods that are pretty common for the patient that's important to us, so we can make sure that we can fit those into the diet as well, as long as they're still allowed. We also identify vitamin and mineral supplementation if needed, and then again, more care coordination. So we work with the team just to make sure that this is going to work out for the patient, and if we need to see you back sooner or later, or however, that's part of our plan. Lastly is in maintenance, and I think it's important to remember that even though you're on a diet for a long time and you're on a maintenance diet, that periodic review is actually important. The reason is we want to make sure that as the child grows that they're still getting their calories, their proteins, and their vitamins and minerals that they need. And then we can also reevaluate for feeding difficulties. And the reason for that and why that's important is because occasionally there will be a relapse or a recurrence of eosinophilia and difficulties that aren't actually noticed because the patient or the child will self-select a new diet, so eating softer foods, and they didn't really notice that they were doing it. But if we were able to review the diet and see, over time what they're able to take, if they've regressed in the types of foods that they're able to take, that's a signal to the providers that we might have an issue here and we might need to relook at that. We also look at weight gain and growth, of course, as they grow. Okay. What do I do? So what does a dietitian want to know? Why I ask all of these questions. I do ask lots of different ways, but I try to find out for myself the actual intakes for each food group for my patients. And in doing that, as well as looking at what they're able to eat throughout a day, will tell me whether or not they're doing okay with textures, if they're appropriate for age. I'm also able to look at the intake to see if the child might have a preference for liquids, if they're using a liquid wash after meals and so on. That's important to the medical team. That's something I try to elicit in my diet intake. And then I also look at the ability to swallow pills if they can. For me, the swallowable adult multivitamin supplements are the best way to get a full array of vitamins in if you can swallow pills and if you're old enough for that dose. But a lot of my patients can't, so then we look at different things. So I also look at their growth pattern. So if I don't already have a weight and height from a previous visit or a visit to a primary care physician, that's something that I like to see. So sometimes I will ask. Obviously, we can't always remember all of those. I can't either, but it's nice to have a growth pattern to compare to. And then, of course, I want to know what your concerns are as a parent for your child's growth and development, or any physical findings that you might know of. And then what do I do with that? I try to work with families to get a good intake of vitamins and minerals, as well as carbohydrates, proteins, fats for age, and especially work on that when we're given a limited diet. At diagnosis, we go through label reading. If that's something that's new to the family, we go through special products, what's available, and that's important for me to know where you live, because special products vary by where you live. And I also talk about cooking methods and alternative foods and ingredients that can be used. I'm available and can do meal planning. That includes lists of new foods. So if we go through your diet or your child's diet and identify the foods that will have to be removed, I like to try to find an alternative for all of those, especially for the younger kids who really have their preferences. We have to decide if there are new foods available on the shelf or in the freezer section, or if we have to make them at home and how to do that. I do try to do my own cooking at home just to get an idea of what's going to work and what's not going to work. And then we also talk about goals for individual food groups. So setting those expectations so that you, as mom or dad, don't feel like your child's not eating enough, but they actually are. So we want to make sure that we have realistic food group goals and portion size goals for their age. Because I don't want my parents to be worrying at home unnecessarily. So let's see. Now we talk about how do we get vitamins and minerals. Like I mentioned before, we try to analyze the food groups. I do a lot of times ask for a 3-day diet record, which is helpful, and then I can decide then if it's a full multivitamin supplement that's necessary, none at all, or somewhere in between, whereas we're just targeting a couple different nutrients. So all of those things help me decide those. Some of the things that we talk about include in the meal planning portion are the challenges with the higher textures. So I have the luxury of working with some great feeding therapists here, and so together we're able to figure out how to get different food groups in depending on where the child is in their ability. So this table just gives you an example of the different textures and how we can get those things in based on what they'll take or what they can take. One of the things that comes up a lot is the chicken or beef or pork or some other animal protein, whereas the earliest or the easiest to take is the purees, such as with broth, but obviously not always age accepted. So if we have a child who's maybe 10 or 12, they might not be too keen on taking a puree. The next step up when they're able is then cubed and cooked in broth or soft cooked, such as in a casserole, boiled. You can boil in broth and serve it with dips, such as ketchup or dressing or gravy, something like that. And then the hardest one to do is the dry cooking method. So grilling or baking, for example, will really dry out something like a chicken breast or a piece of beef. And that's really hard for patients who are not yet in remission. Let's see. Lastly, I think this is second to last. So again, just doing a full diet evaluation is what we do, looking for substitutions, various cooking methods, expected intake volumes for age, recipes, supplementations when necessary, be it a vitamin or formula in some cases. And then remembering that our ongoing evaluation is not just about their growth, but also helping them transition those new life stages, making sure that they're able to work within their abilities, their preferences, and then deal with social situations and what that looks like when they're eating. We talk about the recurrence of symptoms and how that might affect a change in their treatment. So if I find that one of my patients who was previously able to eat, let's say, grilled chicken, and now they've chosen to be vegetarian, we're trying to figure out why, and it turns out that chicken's just really hard for them to eat, and so on. Lots of different examples, but that's something that we would look at and I would talk to the team about. So it's important to tell the dietitian those things. And then we talk about food boredom, especially with multiple food allergy diets. It's really difficult. There's always new products and new ways of cooking and things like that that we can help work with. And then looking at long-term compliance, which often comes up with teenagers especially, and what that means for them. So we have a question about getting a toddler to drink an elemental formula. We're supposed to be using it as a supplement, but he won't drink it because of the smell and taste, which is a common problem. With toddlers, there's a couple things. For one, first of all, overall, the elemental formulas are difficult with the smell and taste, and so covering them, a special cup that has a straw in it as much as possible, and chilling it are the two things that kind of limit the smell. Smell is most of the or has a lot to do with our taste, and so if you can find a way to hide that smell, that will help you. In addition, because they're toddlers, obviously novel containers, things that are fun for them or new, sometimes help them get interested in it. What's important, though, with that is that you offer it the same way every time. You don't want to get them confused, and I'm not sure if it's a toddler that has progressed to open cup yet, or if it's a younger toddler and we're still dealing with a sippy cup versus straw cup and so on. But if that's the case and they're younger, offering it the same way so they don't get confused is important as well. Are there alternatives to Neocate and Elecare if a child reacts to those? I would recommend getting with a dietitian to look at the diet if it's something that you can have foods in the diet still. We can build things around that. I've had several cases where I've had to build basically a formula from other things such as amino acid powder, a base of some sort, whether it's rice milk or something of that sort. I've built several things, and that's really hard depending on how old the kid is and what they're able to take. But I would recommend talking to a dietitian about that. There's a question about starting elimination diets and concern about sugar intake. Not to my knowledge, there is no connection to EOE and between EOE and sugar. If you are concerned about sugar intake overall, you can do a food diary. If you are working with a dietitian, he or she can look at that. You can also enter them in. You can have her enter into the super tracker that I mentioned earlier and look at the percent calories from sugar, percent grams of carbohydrate from sugar. There's a question about a brand of vitamin and calcium supplement that are free of top 8 allergens, including coconut. One of the things that I do use for calcium is, in this instance, when you can't swallow a pill, is Tums. There is the concern for the fact that it is a bicarbonate, and decreasing the acid in the stomach, potentially, or buffering the acid in the stomach, and potentially decreasing then the absorption of the calcium. But I have a lot of patients who do that as their calcium supplementation and do just fine with it. And that connection between the calcium carbonate and decreased absorption of calcium is theoretical. It's not really proven. And then a multivitamin. I use several different multivitamins. It depends what you're looking for. A lot of times I have to piece together some things or just target one vitamin or mineral that I'm trying to supplement. Easy supplements or shake recipes. I can do shake recipes. It depends on the allergens. I often end up having to adjust them based on what my patient's allergen profile is. So I can help more with that question if we get more information. I do not do phone counseling. I'm unable to do that at this time. We are actually at this center looking at telemedicine in the future. I'm not sure how soon, but my hope would be next year. And we can look at doing that then. The allergen profile question that I'm just speaking about, if my patient is given or has milk, soy, wheat, egg-free diet, then I'll use that, and that's what I'm defining as an allergen profile. So if they're allergic to whatever it is, that's their specific profile, and then I use that to decide how I'm going to make up their supplements or their shakes. So it's not something special. I guess it's my own terminology, and I apologize for that. So the allergen, deciding what allergies a patient might have. In our center, we have an allergist who will assess the patient. It's based on experience or exposures as well as allergy testing, and that's not for me to decide, at least in our center. Our allergists deal with that. The question, if wheat is excluded, is it necessary to buy gluten-free or uncontaminated oats? So they're two different things. So a wheat allergen diet, you do not have to buy gluten-free because gluten can be from wheat, rye, or barley. I would recommend buying uncontaminated oats in that case, only because what we know about oats is that they are cross-contaminated with wheat, and that is why oats would, on a gluten-free diet, be not allowed unless they're uncontaminated or deemed gluten-free. So a little bit of a convoluted answer, but no, you don't have to buy gluten-free necessarily, but I would recommend buying the uncontaminated or gluten-free oats in that case. I have a question about, have you found that some children can tolerate a food for several weeks and then react to it later? Absolutely. Depends on the case, and there are many different reasons for that. Is cross-contamination with other foods in the household a problem? Yeah, it is a concern, definitely, and so we try to talk to our families about avoiding cross-contamination, whether it's sharing plates, bowls, etc., that have not been washed. What we do know is that hot soapy water will wash things as long as there isn't food left on a container or a bowl or whatever it is, and that would be fine. The exception to the hot soapy water rule of thumb would be porous things. So let's say a wood cutting board that would be porous and then difficult to actually clean all of that out. Are there alternatives to Miralax that are helpful for children? As a dietitian, I always try to look at the fluid and fiber intake, and so sometimes it's a matter of adjusting that, either adjusting the fluid intake or adjusting the fiber or both. There are fiber supplements if that happens to be the problem, but I will say it's hard to say what the Miralax is for, other than obviously helping to stool. But medically, there are lots of reasons for constipation, and so as my fiber and fluid is a good rule of thumb, it's not the answer to everything. So I would talk to your physician about that. Do I use any particular cookbooks? I'm kind of laughing. I cook a lot, and I drive everybody crazy because I just do a little bit of this and a little bit of that, and it always works out. But I really like the cookbook from APFED. I'm trying to dig on my, here it is, the Extreme Cooking for Exceptional Diets. I do use that as kind of a base for the really difficult diets and then build from there. I really make up a lot of recipes as I go. I try them out at home. I make sure they work. But I never have, I need to start writing them all down. So I apologize. Other than that, I go through lots of gluten-free cookbooks. I find things like that that are helpful, but otherwise I throw things together. I'm so sorry. I'm terrible with the cooking. Well, terrible in that I make it all up as I go. There's a question about some younger kids, toddlers, who are on elemental diets with multiple IgE allergies, with very few safe foods, and what foods to introduce first. Really need to work with your allergist on whether or not those IgE allergies are safe to introduce, and in what order. That's not something that I can guide on. Do I recommend starting with raw or fresh fruits and vegetables? I'm not sure the difference between raw and fresh, or if the question is between fresh fruits and vegetables and other things. There's a question about a young child who can only eat 3 foods, and will this be sustainable going forward for growth? My guess is not. Not knowing what those 3 foods are, but I don't know anybody who can sustain growth on just 3 foods necessarily. So that would be worth looking at, and also making sure that that little one is getting vitamins and minerals supplemented that aren't in his 3 foods. Raw or cooked, I got it. So if we're talking about a young child, you're going to have more success with a cooked fruit or vegetable. If they're newly diagnosed or having trouble again, I would absolutely go for the cooked first, just to establish success. You never want to set them up for failure. So if you give them raw, let's say you handed them a raw apple, for example, and they hadn't had any apple, and the allergist said, you know what, we can go ahead and try apple, I would go for the cooked first for 2 reasons. The allergist is probably going to tell you to go for cooked as well. But for nutrition reasons and actually eating, I would go for what's going to be more successful, because the last thing you want to do is have a failure in terms of unable to swallow the food, and then the child's not going to want to eat it at all, and then you're kind of back at square one. So I'd go with easier to chew and swallow first when you're doing that. The question's about allergens, so the allergist is probably going to tell you cooked first anyway. On that same topic, I'm going to see if I can show this. One of the things we talk about in feeding, we do this as dietitians too, is making sure that we have reasonable expectations for foods. So if you're offering new foods, making sure your expectations as mom or dad are that this is a new thing to them and they're not going to accept it right away. It's going to take several tries, sometimes 10, 15 or so presentations of a food, and it's okay for them to just look at it, to touch it, and so on, and not actually eat it yet. It takes a while. We need to have those reasonable expectations, because if we don't, as parents, we just get really frustrated and move on and give up, and it's just not fair to ourselves to kind of give that up. Making sure that they do have an age-appropriate amount of food, so it's not scary, and then also, as much as possible, having the family or community, whoever they're eating with, is eating similar or the same foods if possible. That's just something I threw in there as well.
I'd like to thank Michelle very much for taking time out of her busy day to be here, and thank you so much for a great webinar, and thank you to all the questions, the people who asked questions, really appreciate it. And I hope you all have a wonderful holiday, and we're going to go ahead and log off now. So thanks again, Michelle, and I hope you all have a wonderful evening.